Good morning, students. Today's class we will see about asphyxia neonatal. Asphyxia neonatal is the respiratory failure in a newborn, a condition caused by inadequate intake of oxygen before, during, or just after birth. Definition of birth asphyxia is defined as reduction of oxygen delivery and accumulation of carbon dioxide owing to cessation of blood supply to the fetus around the time of birth. Essential criteria for prenatal asphyxia include profound metabolic or mixed acidemia in the umbilical cord blood, persistence of low upgas score less than 3 or 4 for more than 5 minutes, signs of neonatal neurologic dysfunction like seizures, encephalopathy, tone abnormalities, evidence of multiple organ involvements such as kidney, lungs, liver, heart, and intestine. Etiology. Pathologically, any factor which interfere with the circulation between maternal and fetal blood exchange could result in happens of perinatal asphyxia. These factors can be maternal delivery factor and fetal factor. Maternal factor include hypoxia, anemia, diabetes, hypertension, smoking, nephritis, heart disease, elderly multi or young primary. Delivery conditions include abruptio placenta, placenta previa, prolapse cord, premature rupture of membrane. Fetal factors include multiple pregnancy, congenital or malformed fetus. Pathophysiology. When a fetal asphyxia happens, the body will show a self-defense mechanism which redistributes the blood flow to different organs called inter-organ shunt in order to prevent some important organs including brain, heart, and adrenal from hypoxic change. First is the non-brain organ injury. Hypoxia, diving, seizure, reflex shunting of a blood to brain and adrenals, heart and away from lungs, kidney, gut and the skin. Second, the next step is the cerebral cortex lesions. Asphyxia continues, shunting within the brain, anterior circulation suffers, posterior circulation is maintained. If it is abrupt and severe, there is not time for compensation. Thalamus and brainstem injury will be included. For the first one is hypoxellular damage. There are reversible and irreversible damage. Reversible damage include hypoxia may decrease the production of ATP and result in the cellular functions, but these changes can be reversible if the hypoxia is reversed within a short period of time. Irreversible damage, if the hypoxia exists in a long time enough, the cellular damage will become irreversible. That means even hypoxia disappear, but the cellular damage are not recovered. In other words, the complications will happen. Asphyxia development. In primary apnea, breathing stops, but normal muscular tone or hypotonia, tachycardia, and hypertension happens early and shortly. Self-defense mechanism, no damage to organ if corrected quickly. Secondary apnea, its features of severe asphyxia or unsuccessful resuscitation usually result in damage of organ functions. Target organs of perinatal asphyxia: kidney 50%, brain 28%, heart 25%, lung 23%, liver, bowel, bone marrow less than 5%. The clinical manifestation of fetal asphyxia: fetal heart rate shows tachycardia followed by bradycardia. Fetal movements first will increase, then it will decrease. Amniotic fluid will be meconium stained. Assessment include fetal heart rate slows, electronic fetal monitoring should continue, persistent late deceleration of any magnitude, persistent severe variable deceleration, prolonged bradycardia, decrease or absent beat-to-beat variability, thick meconium stain, amniotic fluid, fetal scalp blood analysis shows pH less than 7.2. Effect of asphyxia on central nervous system: intracranial hemorrhage, hypoxic ischemic encephalopathy. Cardiovascular includes bradycardia, arrhythmia, hypotension, myocardial ischemia. Respiratory system apnea. The kidney, acute tubular necrosis, GIT, necrotizing enterocolitis, hematology, disseminated intravascular coagulation. Metabolic include hypoglycemia, hyperglycemia, hypocalcemia, hyponatremia. Specific treatment for birth asphyxia is based on baby's age, overall health and medical history, severity of baby's condition, the baby's tolerance for specific medications, procedures or therapies, expectation for the course of condition. Treatment may include giving the mother extra oxygen before delivery, emergency delivery or cesarean section, assisted ventilation, and medication to support baby's breathing and blood pressure, extracorporeal membrane oxygenation or ECMO. Management of a neonatal with perinatal asphyxia starts from the labor room. In the obtain arterial cord blood for analysis, transfer the baby to an NICU. If the Apgar score is between 3 at 1 minute, prolong bag and mask ventilations and then start with chest compression. Management in an issue include maintain a normal temperature, avoid hyperthermia, maintain normal oxygenation and ventilation, maintain saturations between 90 to 95% and avoid hypoxia or hyperoxia, avoid hypercapnia, means hypocarbia as this would reduce cerebral perfusion, avoid hypercarbia which will increase the intracranial pressure and predispose baby to intracranial bleed. Maintain normal tissue perfusion, statin IV fluid, administer dobutamine or dopamine to maintain adequate cardiac output as required. Do not restrict fluid as this practice may predispose the babies to hypoperfusion. Restrict the fluid only if there is hyponatremia secondary to syndrome inappropriate secretion of ADH or if there is renal failure. Maintain normal hematocrit metabolic values. Maintain blood glucose levels between 75 and 100 mg per deciliter. Correct anemia and maintain the hematocrit between 45% to 55%. Check blood gas, detect metabolic acidosis as needed and maintain pH above 7.3. In case of severe asphyxia, provide calcium and maintenance dose of 4 ml per kg per body weight. Treat seizures and nutrition, start oral feeding once baby is hemodynamically stable. Miscellaneous include administer vitamin K 1 mg per kg to all babies with perinatal asphyxia. Role of special investigations like electroencephalography prognosis is likely to be poor if the EEG shows long period of inactivity more than 10 seconds, brief period of burst with small amplitude burst, interhemisphere asymmetry and asynchrony, isoelectric and low voltage. Nursing management include first observe a newborn that has been successfully resuscitated for following constellation signs like absence of spontaneous respiration, sexual activity in the first 12 hours after birth, decrease or increase urine output, which may indicate acute tubular necrosis or syndrome of inappropriate antidiuretic hormone, metabolic alterations, increase in intracranial pressure marked by decreased or absent reflexes. Decrease noxious environmental stimuli, monitor the infant's level of responsiveness, activity, muscle tone, and posture, administer prescribed medications, provide respiratory support, monitor for complications, measure and record intake output, check every voiding for blood protein and specific gravity, check every stool for blood suggesting necrotizing enterocolitis, take serial of blood glucose determination due to hypoglycemia and monitor serum electrolytes, administer and maintain intravenous fluid to maintain hydration and fluid and electrolyte balance, provide education, emotional support for the family. Thank you. Thank you for listening. If you have any doubts or clarification, please do comment.